questions. Let's start with gentleman in blue blazer.
Thank you for speaking to us today, Dr. Atlas. So you said earlier that there shouldn't be caps on drug prices, necessarily like government mandated caps. Do you think that there should be government oversight in terms of drugs like Daraprim that were raised from $13 a pill to $750 a pill? Do you think that there is a role of government in actually regulating any type of drug prices or massive hikes in those prices?
Yeah, and that's a good question, because that's one of the things that prompted the concern. And the concern, I have the slides which I didn't show, is unanimous, no matter what your party, what your demographic, what your position in Congress, about drug prices and the rapid rise of extraordinary prices on certain drugs, as well as the super obnoxious drug CEOs that testified in front of Congress, really prompted that. So here's the way I answer it. Drug prices, the vast majority of drugs in the United States, first of all, are not that. The vast majority of drugs, over 85%, are generics, actually. So it doesn't really apply to most drugs, that kind of logic. In these rare instances, there is a role to figure out what to do about these drugs. And I prefer to let private sector figure this out, because there's a lot of transparency of the fact that the drugs are so expensive that change the dynamic. The drug companies are all aware now that because of this airing of the facts, they're under a tremendous amount of pressure. And so there are different, right now what's happening with that kind of situation is that there are new proposals coming from private sector in joint discussions with the government on how to pay for these things. A different way than paying the way we normally pay. In other words, either spread out over time and have risk pools for drugs themselves, et cetera. So I don't know if I would put it in the category of regulation, but I think there's a lot of creativity needed to address these kinds of things. Because the last thing we want to do, and the unintended consequence is what happens with regulations in healthcare, is dry up the supply of the drug. So the question is, are you better off having no drug? And the answer is no, in my opinion, even though I don't have those diseases. So it's a complex policy. There's a lot of things being looked at. But one thing I would say is a very bad move that is being contemplated by the Trump administration. And that is to tag our prices to prices of other countries. I'm saying this because I'm anticipating that someone will ask this question. Because I didn't show the data, but we pay way more for drugs, the same drugs, than people in other countries. So one of the proposals that's being sort of considered is to tag our prices to the drug prices of other countries that pay less. Well, the problem with that is when you import other countries' drug prices, you're literally importing their price controls. And when you import there's a reason why we have these drugs faster and more of these drugs than everybody in Canada, everybody in England, everybody in every other so-called competitive healthcare system. If I'm a patient, I don't want that kind of government policy to cause my drug to be unavailable. I really don't want that. That's the worst possible outcome to me. So I think it's complicated. I think there's more and more transparency that's needed, and there are many obstacles that inadvertently, behind the scenes, create drug prices elevations here in the United States that need to be addressed. And the Trump administration, many people, including the agencies, are aware of these, and I and others are in constant discussion about this. But it's a difficult problem. Yes.
Thank you so much for your presentation. Do you think that doctors in the United States, or medical professionals in general, I should say, are being paid too much for their services, or do you think that's more so set by the market? And do you think that's kind of based on the supply of medical professionals that you talked about earlier? And if so, what do you think would be the best way to do that? But obviously, diverge on that second half if you disagree.
Mm-hmm. No, well, it's not up to me or anyone else to say that somebody else is making too much money. That's my opinion. On the other hand, it is really outrageous that there are obstacles put in place to limit competition. So I don't really look at how much people are making, but I'm looking at inappropriate barriers that are anti-consumer barriers that hurt patients, and secondarily, likely raise incomes. It's not so much that I'm targeting the income. I want competition. And we know from every other industry, there's a reason why your iPhone or my Samsung doesn't cost $10,000. It's a supercomputer compared to what we used to think about. It's because of competition. And by the way, this idea of price transparency, if I may diverge and talk about something that's my favorite topic. Price transparency is critical to having people be able to discern value and make decisions. And so there are laws being touted to force transparency. But you'll notice that there are no laws to force visibility of prices in anything else. Why? Because consumers are in charge of making the purchasing decision and care if it's more expensive. They don't want to spend extra money. You don't force the Apple Store, you must post your prices. Of course not. Nobody's going to buy anything without knowing what it costs if they're paying. And so this artificial construct that has evolved and worsened really under the ACA is that it doesn't matter what it costs, who cares, I'm not paying. Although, of course, in the end, we are all paying. Yes, first row. You too.
Thank you, doctor. Have you studied the Surgery Center of Omaha or some of these other models that refuse insurance and offer like a price menu at the beginning of purchase? I'm wondering if you think that that's a model that could be replicated on a larger scale, or if we could incentivize that as a policy matter.
Yes, I mean, that's a very good question. There are several, actually, not just that one, but there are several independent clinics and doctors who have decided, okay, this whole system where there's this bizarre concept of reimbursement. In other words, it's the only thing I know of where you say what something costs and your reimbursement rate is calculated. You get 30% or whatever. And in fact, that number is determined by Medicare. By the way, I'll answer your question in a second, because almost all private insurance reimbursement rates are calculated on the basis of Medicare. So Stanford will negotiate a contract with Blue Cross, and they'll say, okay, Blue Cross, we'll pay you 1.2 times what we pay Medicare. Okay, so you see from that logic that actually government is setting the prices of medical care overall in the United States. It's not a free market system. Your question, though, is very good. It points out the movement, the trend towards saying, okay, we're just going to show our prices. We're going to accept cash only. And it's very good to get prices down. Anything that improves competition, I'm for. And so I'm for that. It's still limited, and limited in a lot of ways because it's regional. It's not going to work so well for major surgeries, probably. It might exclude a lot of people who are low income and all this. But to me, the role of government, so I think it's a great idea, it improves competition. The role of government is not to be the insurer. The role of government is to help people pay who don't have enough money to pay to get private health care. We want everyone in the United States to have access to the excellence of American health care. And right now, there's a parallel system for poor people that is unacceptable to anyone in Congress for themselves. And you can look up the quotes on what they've said when President Obama and many others have been asked, will you use this government insurance? And they said, well, no, not for my family. So the answer is yes, better competition is better for everybody. And I would like to shift Medicaid and all the government programs to giving money to get people into this excellent medical care system. You're next.
Thank you. You talked about making prices more transparent to consumers, which I think it could be a good idea, but I guess I'm curious about how making the way that our physicians are being paid also more transparent, because it seems like physicians can respond to changes in billing schedules, and as consumers we're not fully aware of these changes, and whether you think it would be a good idea to make that more transparent as well.
Yeah, I think, the way doctors are paid in the whole kind of very complex system, it's true that more transparency, of course, is better. There's no question about that. The problem is that when you start, there's only certain things that people are going to clue in on. And so I think there's a more fundamental first step. And what I'm outlining are the more fundamental first steps, which are to make people care about what it costs and to give them control of the money and an incentive to save money. So yes, all these things are totally obscure. I mean, anyone who's on Medicare, if you ask your grandparents or parents, no one can decipher a Medicare bill. It's so complicated. You get bills from multiple different sources. It's all just the payment to doctors and hospitals is so out of control with all kinds of administrative things and codes and things. We're never going to totally simplify it because it's complicated in a sense by its nature, because it's so diverse in what we do as doctors. But the fundamental thing really has to be done first before we sort of what I would call give information that isn't really going to move the needle. Nobody's going to understand all of these CPT codes and all this bizarre stuff. Even the doctors and their administrators don't understand them. Yes.
Hi, good morning. Thanks for coming out. Two quick questions. Number one, with the number of baby boomers retiring every day, about 10,000 or so, if I'm correct, and what is it called? With baby boomers retiring at a very large rate, low fertility rates in general, and strict immigration policies, how do you think the federal government will raise adequate funding for a single-payer system without hiring taxes? And number two, you mentioned in one of your slides that obesity is still a very big problem in the United States. Would you classify obesity as a disability?
Okay, so the first question is, how would you pay for a single-payer system without raising taxes? Well, that's impossible. No one even proposing single-payer would say you can't do it without raising taxes. In fact, no one who proposes, well, I don't think they do. If you're going to use a single-payer system, there will be a massive increase in taxes. There really shouldn't be any argument about that. That doesn't mean that you'll be spending more on health care. In fact, it's a bad argument for people opposed to single payer to say the cost is the reason why we wouldn't do single payer. That's not the reason. Single payer costs less all over the world than I just showed the first slide I showed. Single payer costs less. Why? Because you don't have the access to medical care. I can make single payer free by refusing to pay for any medical care. You can't do that with the system we have. Single payer is not more costly. On the other hand, you wouldn't be paying for health care the same way. You'd have massive tax increases, but you could adjust the availability and quality of care to the detriment of patients, but you could make it cheaper. So that's sort of a complicated answer to point number one. Point number two, you asked, is obesity a disability? It ends up in disability. In fact, it's the biggest cause of disability in the United States. And the disability comes from the diseases associated with obesity: diabetes, musculoskeletal problems, particularly spine and hip, and heart disease. Those are the three causes of disability directly related to obesity. So obesity alone is really not the disability. It causes the diseases associated with disability. And by the way, lifestyle changes, lifestyle behaviors, the big three are smoking cigarettes, obesity, and alcoholism. According to every health agency in the world, these are lifestyle issues. They are attributed They cause 45% of all cancers in the United States and cancer deaths in the United States. I mean, it's a huge problem for a voluntary lifestyle behavior. Yes.
Thank you, Doctor. In one of your early slides, you reach, in my opinion, a very sensible conclusion that the U.S. is a world leader in terms of, medical innovation. But your slides seem to use, are based on number of U.S. patents granted, number of U.S. FDA approvals granted, which doesn't seem very logical to me, because you could argue, hey, like North Korea is a world leader because North Korea gets the most North Korean patents granted or the most North Korean FDA approvals granted. Is there perhaps a different way that you can argue that conclusion?
Well, that's true on the U.S. patent slide, but I don't know if I showed the drug patents. But the reality is that these are all the drugs for the slide I showed of the cancer drugs, 45 United States and half for these other countries. Those are all the cancer drugs. They're not just the cancer drugs, they're all the available cancer drugs. So it's not really misleading. It just points to the problem the criticism is that, well, the U.S. is the generator of all of them, all of them. The denominator is not just those in the U.S. The denominator is all of the drugs. And when you look at the time to approval, there's a lot of detailed studies on this, for the same drugs and the introduction of the same drugs, no matter where they were originated. It's always faster in the United States, shorter introduction to patients. So it's not really that for the drug issue, generally speaking. I mean, there may be a single exception or something. Well, I don't know about the China data. I mean, I'm not sure about that. But the data from EU and everything, the time of approval for the same drugs, even if the origin was in the U.S., is shorter in the United States, meaning available for patients. One more question. Yes.
Good morning. So my question is in regards to prescription costs as well. What would you say to, this is a theory I've heard before, that the rest of the developed world and the single-payer healthcare systems of other countries operate in and I'm using this word lightly, like a parasitic relationship with the U.S., in that because we have access to a wider variety of pharmaceutical drugs at earlier times, that we in fact discover for the rest of the developed world what pharmaceutical drugs are beneficial, what pharmaceutical drugs are maybe slight improvements on the generics, and by doing so, the rest of the developed world will then never have access to those drugs that we've essentially determined are not very beneficial. So, for example, you look at the opioid crisis. We have obviously discovered that there are problems with those drugs, and to the extent that those are now not available, to the extent that those countries can't make the same mistakes in overprescriptions, things like that, because we've essentially discovered those things for them before those drugs are available to them.
I'm sorry, so what's the question?
My question is, what is your opinion of that theory? I've heard it in other places.
You mean that if because we originate a drug and then we decided we don't want to continue it because it has problems, other nations are suffering from that? Is that right?
Other nations, because they have longer wait times until those drugs are available in their countries, because we have greater access to them right now, they never get them for a couple of weeks because of the regulatory hurdles. Because of that,
it's not just weeks, but go ahead.
Right, weeks, months, years, exactly. But because we essentially, I'm saying that the most popular drugs in the U.S. eventually become available in those other countries because they're popular in the U.S. and they're continually used over and over again. And because eventually the price is lowered through the company not needing to make back all of its money that it invested on research and development. I guess my question is, when the countries that have access to our drugs eventually, why is it that those are the drugs that become available eventually? And is it because the popularity in the U.S. or the resiliency to it in the procedure is the one that eventually, that's why single-payer healthcare systems in other countries choose to get that
well,
drug?
I mean, I'm not sure how to answer the question, but they don't approve a drug in the EU because it's popular in the US. That's not how it works. I mean, they have an efficacy, there's a safety and an efficacy process. Is the drug effective? And it's less available in these other countries specifically because the controlling entity, the government, the payer, has decided that they're not going to spend that kind of money on a drug, or they're going to delay its use because there are cheaper drugs, and we don't want that available for people. I'm sorry, I probably can't answer the question because I can't quite grasp it. But anyway, I think we'll have to stop. Thanks very much.